Welcome to the Deep Dive, your shortcut to being truly well-informed. Today, we're plunging into a foundational and frankly critical area of medical knowledge, gynecology. It impacts so many lives.
And our source material today is, well, it's excellent. It's a chapter from a surgical textbook.
Yeah.
Dense, yes, definitely dense, but absolutely packed with essential info. Covers everything from the intricate map of pelvic anatomy, right through to common gynecological conditions, how we diagnose them, and, the different ways we manage them, including surgery.
Our mission today is pretty ambitious, but if you're listening, you want to go deep, right? You want to master this information, not just get the highlights. The goal is to unpack all the essential insights from this chapter. We'll guide you through the complex anatomy, help you understand the nuances of common conditions, things like ectopic pregnancy, endometriosis, fibroids, and really get a handle on their diagnosis and management.
Yeah, the idea is for you to walk away with an understanding that feels, well, almost like you've been there, akin to a professional navigating this field, really mastering the core material presented in this text.
Think of us as your guides through this complex territory. We're going to cover every major topic, every key concept mentioned here.
It's about understanding the why and the how at a level that gives you that, that properly informed edge, almost like having shadowed in the clinic or the operating theater, understanding the fundamental principles.
Yeah. Let's get started then. We have to begin at the absolute beginning, the foundation, pelvic anatomy. Our source starts right back there, looking at the developmental origins.
Absolutely. It's fascinating, really. The female reproductive system, it doesn't just appear. It takes shape quite early in development. The source tells us that these reproductive structures start differentiating after the 7th week.
And they don't all come from the same place embryonically.
That's a key point. For females, it's the Mullerian ducts. These are the precursors, the starting point for the internal organs. The uterus, the fallopian tubes, the cervix, and the upper third of the vagina.
Just the upper third.
Just the upper third. The lower 2/3 of the vagina actually develop separately from something called the urogenital sinus. And knowing this dual origin, it's actually important for understanding certain congenital anomalies. Sometimes those Mullerian ducts don't fuse right or develop fully, and you can get issues like a double uterus or even an absent vagina. That's a bit beyond this chapter, but the source grounds us in that basic biology.
Right, very fundamental. So let's start from the outside and work our way in. The source talks about the external genitalia, the vulva.
The vulva, yeah. It has specific borders that are important landmarks. Anteriorly, you've got the mons pubis, that fatty pad over the pubic bone. Then posterolaterally, it's bordered by the labiocrural folds, which kind of separate the vulva from the inner thigh.
And covering the entrance, the introitus.
Those are the labia majora. And then medial to those, you have the labia minora, the thinner folds. They fuse together at the front, anteriorly, sort of protecting and enclosing the clitoris.
And the source makes a point about the clitoris itself.
It does. It highlights that the clitoris contains erectile tissue, structurally very similar, homologous to the penis, which is, of course, key to its function in sexual response.
And at the very back edge of the introitus.
That's the fourchette. It's a small fold of tissue there. Seems minor, maybe, but it's clinically quite relevant, especially in childbirth. It stretches a lot to allow the baby's head to pass. It's often where natural tears happen or where an episiotomy might be performed.
Okay, moving inside now, we get to the vagina.
The source describes it as, well, an elastic distensible tube, typically around 6 to 7 centimeters long, and it angles upwards and backwards from the introitus. It's not just a straight tube, though. Its relationship with the cervix above is important.
Creating those spaces, the fornices.
Exactly. The cervix pokes down into the top part of the vagina, the vaginal vault, and this protrusion creates these little recesses around it, the anterior, posterior, and lateral fornices.
And these aren't just anatomical details, they matter clinically.
Absolutely. Especially the posterior and lateral ones, because the vaginal vault sits right below the pouch of Douglas, that deepest point in the pelvic cavity between the uterus and the rectum. So during a bimanual exam, a clinician can actually feel pelvic structures, organs, or any abnormal masses through the vaginal walls in those fornices. It's a critical part of the physical assessment.
And its neighbors.
Right. The source clarifies those relationships, too. The urethra and the bladder neck are just above the anterior vaginal wall. And behind the posterior wall, you've got the perineal body and the rectum.
Okay, moving further up still, we reach the uterus.
The uterus, often described as looking like an upside-down pear. It's also flattened, front to back, anteroposteriorly, and that flattening gives the inside cavity its characteristic shape, sort of flat, triangular space.
And it has two main divisions.
Yep. The main body, the corpus, and the cervix, which is like the neck of the uterus, extending down into the vagina. The source points out it's not just floating there, it gets support from ligaments attached mainly to the cervix. Things like the transverse cervical, pubocervical, and uterosacral ligaments.
And these aren't flimsy ligaments.
No, they're described as consisting of condensed connective tissue. They provide really important structural support.
Let's focus on the cervical canal for a moment.
Okay, the canal. It's the pathway connecting the outside world, essentially, via the vagina, and the external os, that's the opening you can see on a speculum exam, up into the uterine cavity via the internal os. In a woman who isn't pregnant, it's usually about 2 to 3 centimeters long.
And its size relative to the uterus changes.
It does, yeah. The source notes that the ratio of the uterine body length to the cervical length changes quite a bit depending on hormones and age. Before puberty, the cervix actually makes up a larger chunk of the total uterine length, but after puberty, with hormonal influence, the uterine body grows significantly, changing that ratio.
The uterus isn't fixed rigidly in place, is it?
Not at all. Its position is quite dynamic. The cervix tends to stay relatively central within the bony pelvis, but the uterine body can pivot around it. The most common position. That's anteverted, angled forwards relative to the vagina. And it's normally quite mobile. Its position can shift depending on, say, how full the bladder is, or just changes in body position.
But variations are normal, too.
Oh, absolutely. A retroverted uterus, angled backwards, is a common normal variant, but it can also be abnormal, caused by things like weakened ligaments or adhesions from diseases like endometriosis sticking it back there. The source also mentions flexion, the angle of the body relative to the cervix itself. It can be anteflexed, a bent forwards, or retroflexed, bent backwards. And all of this version, flexion mobility can be assessed during that bimanual examination.
Right. What about the uterine walls and that all-important lining?
The walls themselves are pretty substantial, about 1 to 2 centimeters thick, made of smooth muscle tissue, the myometrium. And inside, lining the cavity, is the endometrium.
The endometrium, where all the action happens for periods and pregnancy.
Exactly. It's incredibly dynamic. Changes cyclically throughout the menstrual cycle. It's got 2 layers. The basal layer, right next to the muscle, which doesn't get shed during menstruation. And then the functional layer, which grows from the basal layer each cycle.
And that functional layer is hormone sensitive.
Highly sensitive to estrogen and progesterone. It thickens up beautifully each month, preparing for a potential implantation of a fertilized egg. If conception doesn't happen, well, that whole functional layer gets shed. That's menstruation.
Assessing uterine size seems crucial.
It is, yeah, for diagnosis, for planning surgery. But the source points out that just by feeling palpation, especially in lean patients, it's often subjective unless you've got imaging. And the most common reason for the uterus to be enlarged, apart from pregnancy, of course.
Fibroids.
Fibroids. Those benign tumors of the myometrium. We'll definitely be talking more about those later.
And there's a specific way uterine enlargement is often described clinically.
Yes, particularly when it's due to fibroids or maybe adenomyosis. Clinicians often describe the size by comparing it to how large the uterus would be at a certain stage of pregnancy, like saying it's a 12-week size uterus. It's a quick, common way to communicate the degree of enlargement, even if it's a bit subjective.
Okay, moving out sideways from the uterus now. The fallopian tubes.
Right, located at the top corners, the cornua of the uterus. They're thin, muscular tubes about 10 centimeters long. They're the connection, the conduit between the ovaries and the uterus.
They have different parts.
The source describes 4 sections. The intramural part, actually embedded within the uterine wall itself. Then the isthmus, which is a narrow segment. The ampulla, that's the wider, more winding part where the fertilization usually happens. And then the fimbriated, opening the finger-like projections at the very end near the ovary.
And the width varies.
Yeah, the source points out the isthmic and intramural parts are quite narrow, whereas the ampulla widens out considerably.
They're contained within that peritoneal fold, the broad ligament.
Mostly, yes. They run within the upper part of the broad ligament. That's the sheet of peritoneum draping over the uterus and tubes. The broad ligament also contains important blood vessels and the round and ovarian ligaments. But, and this is important, the fimbriated end and part of the ampulla, they're actually free, not fully enclosed. This allows them to move and sweep over the surface of the ovary to capture the egg when it's released.
Which brings us nicely to the ovaries themselves.
The ovaries. They're described as flattened, sort of ovoid structures, typically about 3 to 4 centimeters across in a reproductive aged woman. They're suspended from the back of the broad ligament near the sidewall of the pelvis. They're connected to the uterus by the ovarian ligament.
And their blood supply.
The ovarian blood vessels, the main artery and vein, come down from higher up near the aorta and vena cava. They travel within the infundibulopelvic ligaments. These are basically continuations of the broad ligament that extend up towards the pelvic brim.
It's becoming really clear that you absolutely need a solid grasp of this whole intricate network organs, ligaments, folds, spaces to work safely and effectively in this field.
That's a huge takeaway from this source. It explicitly states that a sound understanding of pelvic anatomy is the bedrock, the foundation for surgical excellence and safety. You have to know not just where things are, but how they're suspended, where the crucial vessels and nerves run, and what's nearby.
Which leads directly into identifying those critical surgical landmarks. The source details some key ones.
The sacral promontory is highlighted. It's like the summit, the high point of the true pelvis, a major reference. Pelvic pathology might grow upwards, but its origin is considered below this point. Anatomically, it's that bony projection at the top of the sacrum, level with the L5-S1 disc space, really. And it's a landmark for major vascular bifurcations. The aorta splits higher up, but the common iliac vessels bifurcate into external and internal iliacs right around this level.
And the ureter does something important here, too.
Critically important. The ureter, carrying urine from the kidney to the bladder, makes a crucial crossing at the pelvic brim near the sacral promontory. It crosses over the common iliac bifurcation, transitioning from a more lateral position to run medially down into the pelvis.
So you're always thinking, where's the ureter during pelvic surgery?
Always. Its path is intimately related to all these structures. And at that same level, near the promontory, the source also mentions the superior hypogastric nerve plexus. That's an important bundle of autonomic nerves.
Okay, talking about those big vessels bifurcating, let's trace the blood supply.
Right. The aorta splits, usually around the L4 vertebra, into the right and left common iliac arteries. Then, as we said, around the level of the sacral promontory, each common iliac divides into the external and internal iliac arteries.
The external iliac mainly heading down to the leg?
Primarily, yes. Supplies the lower limb, but it gives off one important branch in the pelvis, the inferior epigastric artery. And the source gives a practical tip here. You need to know where that artery runs, especially when doing laparoscopy, to avoid injuring it when placing lateral ports. That can cause significant bleeding.
So the internal iliac artery is the main player for the pelvic organs.
Exactly. It dives down into the pelvis and divides into an anterior and a posterior division. The anterior division is the workhorse. It's the main blood supply to the vital pelvic organs like the uterus, bladder, vagina, rectum. The posterior division mainly supplies the muscles of the buttock, the gluteal region.
And that anterior division runs close to the ureter.
Very close. It travels parallel to the ureter for a stretch, again highlighting how tightly packed these structures are.
What are the key branches coming off that anterior division?
The first major branch is usually the uterine artery. Then comes the superior vesical artery, supplying the bladder. And then the internal iliac continues as the obliterated umbilical artery, a remnant from fetal life. The source points out something surgically relevant. There's usually about a 5 to 6 centimeter distance from where the anterior division starts to where the uterine artery branches off. This segment is often where surgeons might perform an internal iliac artery ligation.
Why would they do that?
It's a technique used to control massive pelvic bleeding, sometimes in obstetric emergencies like postpartum hemorrhage, or sometimes preventively in really extensive cancer surgeries like pelvic exenteration. Ligating the internal iliac here significantly reduces blood flow to the pelvic organs, buying time or controlling hemorrhage.
So navigating these vessels needs pinpoint accuracy. What about the nerves supplying these organs?
The source mentions the autonomic nervous system. Sympathetic nerve fibers come via the inferior hypergastric nerve, originating from spinal levels T10 to L2. Parasympathetic fibers come from the pelvic splanchnic nerves, S2, S4. These nerve fibers merge and travel together to supply structures like the ureter and the urinary bladder.
And there's a risk during complex surgery.
A definite risk. The source flags that injury to these autonomic nerves during complex pelvic dissection, maybe for cancer or severe endometriosis, can lead to long-term problems. Things like residual bladder dysfunction, difficulty emptying the bladder properly, and also sexual dysfunction.
So it's not just organs and vessels, but the spaces between them that surgeons need to know. The source emphasizes these pelvic surgical spaces.
Yes, these retroperitoneal spaces. They've become a real focus in modern surgical anatomy teaching because understanding and dissecting within these potential planes is key to safe surgery. The source divides them into those found on both sides, bilateral, and those in the midline.
Let's cover the bilateral ones first.
Okay, on each side you have the perirectal space. It's bordered medially by the rectum and laterally by the internal iliac artery. The roof is the posterior leaf of the broad ligament, the floor is the levator ani muscle, and the top border cranially is the uterine artery. Now this space is further divided by the ureter running through it. Medial to the ureter is the medial perirectal space, also called the Okabayashi space. Lateral to the ureter is the lateral perirectal space, or Latsko space.
Okay, perirectal space. What else is bilateral?
The peravesical space. This one is lateral to the urinary bladder. Its medial border is the bladder itself, the lateral border is the pelvic side wall, and the inferior border is the uterine artery. The space is also divided, this time by the obliterated hypogastric artery, into medial and lateral compartments. The floor of the medial space is the levator ani. The lateral peravesical space is important because it contains the obturator nerve and vessels and the pelvic lymph nodes.
So crucial for cancer surgery, like lymph node dissection.
Absolutely. Procedures like radical hysterectomy involve dissecting out these nodes, and the boundary is often the obturator nerve posteriorly. Knowing these spaces allows surgeons to find and remove the nodes safely.
What about the midline spaces?
There's the space of Retzius. This is the space between the pubic bone and the anterior abdominal wall in front and the urinary bladder behind. It connects laterally with those peravesical spaces. The source highlights its importance in urogynecology procedures for incontinence, often access the bladder neck through this space. It's also used in deep endometriosis surgery involving the bladder, allowing for dissection and tension-free repair if needed.
Then behind the uterus.
That's the rectovaginal space. A key posterior space between the posterior wall of the vagina and cervix anteriorly and the rectum posteriorly. Its lateral borders are the uterosacral ligaments. This space is opened up frequently in radical hysterectomies and deep endometriosis surgery involving the posterior compartment.
And one more midline space.
The retrorectal space. This is behind the rectum, bounded anteriorly by the rectum itself. It's explored in really complex pelvic surgeries, sometimes for rectal cancer or deep endometriosis involving rectal resection. The source flags a major hazard here. The presacral venous plexus, lying behind a layer called Waldeyer's fascia. Injury here can cause torrential, life-threatening bleeding that's incredibly difficult to control, needs meticulous dissection.
It really does sound like navigating a complex city map, major roads being vessels, buildings or organs, underground lines or nerves, and these different districts are the surgical spaces. You need to know the whole layout.
That's a great analogy, and the source gives a nod to the people who drew that map. The anatomists and historical figures who describe these structures and spaces, names like Moeller, Douglas, Falloppio, Retzius, Okabayashi, Latsko, Waldeyer-Hartz. Their work built this essential anatomical framework that surgeons rely on every day.
Okay, let's shift gears from the bedrock of anatomy into specific clinical conditions. The source starts with early pregnancy complications, really honing in on ectopic pregnancy.
Ectopic pregnancy. It's such a critical topic because it can absolutely be life-threatening. The definition is simple. Any pregnancy growing outside the uterine cavity. And the source confirms what most people know the most common spot, over 95% of the time, is the fallopian tube.
And pinpointing the exact location is vital for management.
Crucial. The source introduces some updated terminology here. It broadly classifies ectopics as either uterine or extrauterine. Now, a uterine ectopic, under this newer definition, is specifically when the trophoblast invades beyond the normal endometrial-myometrial junction, but it's still within the uterine muscle wall or maybe the broad ligament peritoneum. Everything else is extrauterine.
And even within uterine ectopics, there's more detail.
Yeah, they can be described as complete, meaning totally confined within the myometrium or partial, involving both the myometrium and extending into the uterine cavity itself.
The source gives examples with typical ultrasound findings. Let's highlight a few.
Okay, so for uterine ectopics, a cervical pregnancy, that's implanted below the internal os in the cervix itself. On ultrasound, you look for the absence of the sliding sign, where a normal early sac might move a bit, and often there's noticeable blood flow around the sac on Doppler. Then there's a cesarean scar ectopic, located low down, right near the internal lobes, but specifically with the trophoblast invading into the myometrium at the site of a previous C-section scar. And an intramural ectopic is fully embedded within the uterine muscle wall above the internal os.
And for us read-around ones.
Well, the most common, as we said, is tubal anywhere along the tube. Ovarian ectopics are rarer. On ultrasound, color Doppler might show increased vascularity within the ovary, specifically low resistance flow around the ectopic sac, distinct from the normal corpus luteum flow. Abdominal ectopics are uncommon too and can implant almost anywhere: broad ligament, pouch of Douglas, bowel surface, uterovesical pouch.
The source also mentions some rare but really important variations.
Rudimentary horn pregnancies. Very rare, like 1 in 75,000 to 150,000 pregnancies. They're significant because they implant in a poorly developed horn of the uterus, often associated with the unicornuate uterus. Because they're surrounded by some myometrium, they can sometimes grow into the second trimester if missed. Ultrasound diagnosis relies on seeing that single interstitial tube portion attached to the main uterine body and the pregnancy within the rudimentary horn. They're high risk because they often present suddenly with severe pain, uterine rupture, a major emergency.
And the idea of a residual ectopic.
Right. This refers to when some ectopic tissue remains visible on ultrasound even 3 months after the woman's pregnancy tests are negative and her serum beta-HCG level is below 20 IUL. It means the hormones have resolved, but some non-viable tissue is still there.
What's happening physiologically as an ectopic grows, especially in the tube? Why is it so dangerous?
The source explains the pathophysiology really well. As the placental tissue implants in the tube wall, it behaves like it would in the uterus it invades, looking for a blood supply. It infiltrates the blood vessels in the tubal wall. This causes bleeding, both within the tube and often leaking out into the peritoneal cavity. The fallopian tube just isn't built to stretch and accommodate a growing pregnancy like the uterus is.
So it eventually ruptures.
Exactly. As it grows, it stretches the tube beyond its limit, leading to rupture. And tubal rupture causes sudden, often massive internal bleeding into the abdomen. That's the gynecological emergency that requires immediate surgery.
How common are ectopic pregnancies?
The source quotes an incidence of about 11 per 1,000 pregnancies. And tragically, despite better diagnosis and treatment, there's still a maternal mortality rate associated with it, about 0.2 deaths per 1,000 estimated ectopic pregnancies.
That really underscores the seriousness. What puts a woman at higher risk?
The source gives a clear list of major risk factors. A big one is previous pelvic inflammatory disease, PID, because that can damage the fallopian tubes, causing scarring or blockage. Smoking is another. A history of infertility itself can be a risk factor, often linked to underlying tubal problems. Using an intrauterine contraceptive device, IUCD, is interesting. It's very effective at preventing intrauterine pregnancies, so if a woman does get pregnant with an IUCD in place, it's more likely to be ectopic.
And previous pelvic history.
Crucially, having had a previous ectopic pregnancy significantly increases the risk of another one. Also, any previous abdominal or pelvic surgery, like myomectomy or hysteroscopic procedures, can increase risk. And especially previous tubal surgery, things like sterilization or surgery to open a tube, salpingostomy for a prior ectopic, or tuboplasty to repair tubes. Endometriosis is also listed as a risk factor, so anything that might alter the tube's anatomy or function seems key.
Diagnosing it clinically sounds like it could be tough, given the symptoms can vary so much.
It can be really tricky. The source lists the symptoms and signs, and they overlap with so many other things. Symptoms might include abdominal or pelvic pain, which can be sudden and severe if it ruptures. Amenorrhea, a missed period, is common but not always. Vaginal bleeding is frequent but often light or just spotting, not like a normal period. Breast tenderness, general GI upset like nausea or vomiting, dizziness, fainting, even syncope or blacking out. Shoulder tip pain is a classic sign of diaphragmatic irritation from internal blood, sometimes rectal pressure or pain with bowel movements, and some women, completely asymptomatic, especially early on.
And what might a clinician find on examination?
Signs can include tenderness or a feeling of fullness in the pelvis or abdomen, signs of peritonism that indicates blood irritating the lining of the abdomen, pallor, looking pale from blood loss, abdominal distension, cervical motion tenderness, specific pain when the cervix is gently moved during the pelvic exam. The uterus might be slightly enlarged, but usually not as much as in a normal intrauterine pregnancy. Tachycardia, fast heart rate, and hypotension, low blood pressure, are worrying signs. And in severe cases, shock, collapse, or orthostatic hypertension, getting dizzy when standing up due to blood loss.
Given that symptom overlap, what are the main things it needs to be differentiated from?
The source lists the key differentials. Miscarriage is the big one. Urinary tract infection, an ovarian cyst accident like rupture or torsion, which we'll discuss, and appendicitis. All can cause similar pain, sometimes bleeding. So ectopic always has to be on the radar for women of reproductive age with these symptoms.
So investigations are absolutely vital. What are the go-to diagnostic tools?
If you suspect an ectopic, the first-line investigation is a transvaginal ultrasound scan, TVUS. You're looking for specific features, like an empty uterus alongside a positive pregnancy test. The source says finding no intrauterine gestational sac with a positive test dramatically increases the probability of an ectopic, unless the pregnancy is just too early to see the sac yet. Finding free fluid in the pouch of Douglas, which could be blood, or seeing an adnexal mass near the ovary or tube on the scan also make ectopic much more likely.
What if the ultrasound is ambiguous? Maybe you see something, but it's not clear what.
That's where serial measurements of the serum beta-HCG level come in. You take blood tests, typically 48 hours apart, and it's the change in the HCG level that gives you crucial information. The source gives benchmarks. If the level rises by at least 63% over 48 hours, that's reassuring for a viable intrauterine pregnancy, and you'd plan a repeat scan. If the levels roughly halve, it suggests a failing pregnancy, probably a miscarriage. But if the levels are static or rise or fall only suboptimally, that pattern is highly suggestive of an ectopic pregnancy.
Is there a single HCG level that's diagnostic?
Not exactly diagnostic on its own, but the source notes that a single level above around 1500 IUL, combined with seeing an empty uterus on TVUS, and assuming there hasn't been heavy bleeding suggesting a completed miscarriage, is also very suggestive of an ectopic.
Can laparoscopy be used just to diagnose?
Yes. Sometimes if the ultrasound and HCG levels are still inconclusive, but there's strong clinical suspicion, diagnostic laparoscopy can be used to directly visualize the tubes and pelvis. But the source adds a caution. You can get a false negative if the ectopic is very small and early and just isn't visible yet.
Okay, once the diagnosis is made, what are the management pathways?
The source outlines 3 main strategies. Expectant management, which is basically careful monitoring without active treatment, medical management using the drug methotrexate, or surgical management.
And how is the choice made?
It's a complex decision based on several factors. The woman's clinical condition is paramount. Is she stable? Any signs of rupture? Ultrasound features matter. Is there free fluid? How big is the ectopic? Is there a fetal heartbeat? Is it alive? The serum HCG level is key. And really importantly, it depends on the patient's understanding, her ability and willingness to commit to the necessary follow-up, which can be quite intense, and ultimately her own informed choice.
Who is suitable for expectant or medical management?
Expectant management is usually reserved for women who are completely stable, pain-free, have a low and falling or very low initial HCG, typically 1500 IUL, are definitely committed to follow-up, and where the ectopic is confirmed as not alive and is small, usually 35 millimeter. Medical management with methotrexate is an option for similar patients, stable, minimal pain, committed follow-up, non-alive ectopic, 35 millimeters, but with slightly higher HCG levels, generally between 1500 and 5000 IUL.
The follow-up for these non-surgical routes sounds rigorous.
It has to be. For both expectant and medical management, the HCG levels are checked again on day 4 and day 7 after the initial assessment or treatment. You're looking for a significant drop. A fall of 15% or more between day 4 and day 7 is usually considered reassuring. Then levels are checked weekly until they fall below 20 IUL, considered negative. If the levels plateau or rise, the woman needs urgent review and likely a change of plan, potentially to surgery. And a crucial point. Women managed non-surgically must be counseled about the ongoing risk of rupture and told to seek immediate help if pain worsens or they develop other worrying symptoms.
Let's talk about methotrexate. How does it work?
The source explains it's a folic acid antagonist. Folic acid is vital for rapidly dividing cells, like those in a pregnancy, to synthesize DNA. Methotrexate blocks that process, stopping the growth of the ectopic pregnancy's trophoblastic tissue. But it's a chemotherapy agent, and the source flags potential significant side effects, including liver toxicity. A really critical counseling point is that women must avoid pregnancy for at least 3 months after treatment because methotrexate can harm a developing fetus. Patient selection is key, and unfortunately it doesn't work for everyone. Some women fail medical management and need surgery anyway.
So surgery is the go-to if non-surgical isn't appropriate or fails?
Yes. Surgical management is the preferred choice for women who choose it, those who can't commit to the follow-up, those with significant pain, women with high or rising HCG levels, say 5000 IUL, or if the ectopic is considered alive, fetal heartbeat seen, or is larger, 35 millimeters.
And surgically, there are 2 main things that can be done.
Salpinectomy, removing the entire fallopian tube containing the ectopic, or Salpingostomy, making an incision in the tube, removing the pregnancy tissue, and leaving the tube in place, hoping it heals and stays functional.
How is the surgery usually done? Laparoscopically?
Ideally, yes. The source states laparoscopy is preferred for stable patients. It offers benefits like shorter operating times, less blood loss, shorter hospital stays, and importantly, studies show similar rates of future intrauterine pregnancy compared to open surgery, laparotomy. However, if the woman is hemodynamically unstable, perhaps bleeding heavily from a rupture, then a laparotomy might be necessary for faster access and control of the bleeding.
How do surgeons decide whether to remove the tube, salpingectomy, or try to save it, salpingostomy?
The general guidance, according to the source, is that if the woman's other fallopian tube looks healthy, then salpingectomy, removing the affected tube, is usually preferred.
Why is that? Why not always try to save the tube?
Because salpingostomy, while preserving the tube, comes with specific risks. The source lists about an 8% risk of persistent trophoblastic tissue being left behind, which might continue to grow or produce HCG, requiring further treatment, often methotrexate or repeat surgery. There's also a risk of ongoing bleeding from the tube incision site, and importantly, a higher risk of having another ectopic pregnancy in that same tube in the future.
So women having salpingostomy need careful follow-up too?
Yes, definitely. They need serial HCG tests after surgery until the level is negative to make sure no active tissue remains. And the source adds, if a woman has a repeat ectopic in the same tube where she previously had a salpingostomy, then salpinectomy is recommended that time, regardless of how the other tube looks.
Managing ectopics that aren't in the tube, like interstitial or C-section scar ectopics, sounds even more complex.
They are. The source specifically flags these as being associated with more significant complications, especially severe bleeding. This unfortunately means there is a higher risk of needing a hysterectomy to control life-threatening hemorrhage in these cases. The advice is that these complex ectopics are best managed in specialist tertiary centers with expertise, tailoring the plan based on stability, exact location, and the clinical team's experience.
Beyond the immediate treatment, what's the key message for these women long-term?
A really crucial counseling point highlighted by the source. Women who've had one ectopic pregnancy have a significantly increased risk of having another one in the future. They absolutely need to be advised to seek medical attention very early in any subsequent pregnancy for an ultrasound to confirm the location.
And the practical point about blood group.
Yes, just like with miscarriage, non-sensitized rhesus Rh negative women who have an ectopic pregnancy should receive anti-D immunoglobulin to prevent them from developing antibodies that could affect future Rh positive pregnancies.
The source gives a nod to Christian Johann Doppler here.
Right, acknowledging the Doppler principle. That's the physics behind color Doppler ultrasound, which, as we discussed, is so useful in assessing blood flow patterns, like looking for flow around an ectopic sac or the whirlpool sign in torsion.
Okay, great. Moving away from early pregnancy, the source tackles abdominal pain, starting with acute causes in non-pregnant women.
Right, acute abdominal pain presenting to the emergency department. It's a real diagnostic challenge because the possibilities are so broad. The source lists common causes, both gynecological and non-gynecological.
What are the gynecological ones mentioned?
Adnexal torsion, twisting of the ovary or tube, an ovarian cyst accident, like rupture or bleeding into a cyst, pelvic inflammatory disease, PID, and endometriosis, which can cause acute pain flares.
And non-gynecological causes mimicking pelvic pain.
Things like appendicitis and bowel obstruction are common mimics.
Let's focus on adnexal torsion as the source details it.
Adnexal torsion is a true surgical emergency. It's when the ovary, and often the fallopian tube with it, twists on its vascular pedicle, its stalk containing the blood supply. This cuts off the arterial inflow and venous outflow, leading rapidly to ischemia, lack of oxygen in the ovary, causes severe pain, and can lead to the ovary dying if not treated quickly.
So speed is absolutely critical for diagnosis and treatment.
Essential. The source really stresses this. The quicker you diagnose it and surgically untwist-duce the ovary, the better the chance of saving it and preserving ovarian function. If it's left twisted too long, it becomes necrotic and has to be removed.
How does it typically present? What should make you suspicious?
The symptoms and signs outlined in Table 87.3 are frustratingly nonspecific, so you need a high index of suspicion. The classic symptom is sudden onset, often severe abdominal or pelvic pain. Nausea and vomiting are very common accompaniments, sometimes diarrhea. On examination, there's usually significant tenderness in the lower abdomen or pelvis, and sometimes you can feel a tender adnexal mass. Signs of peritonism might be present if there's inflammation or leakage.
What increases the risk of torsion happening?
Basically, anything that makes the ovary larger, heavier, or more mobile. An enlarged ovary, most commonly due to an ovarian cyst, is the biggest risk factor. Para-ovarian cysts next to the ovary or a hydrosalpinx fluid-filled tube can also twist. And having had torsion before makes you more prone to it happening again.
What investigations help confirm this suspicion?
Blood tests might show raised inflammatory markers like white cell count or CRP, but, and this is key, they can be completely normal. So normal bloods absolutely do not rule out torsion. The most important investigation is ultrasound, especially transvaginal. The source lists several key features to look for.
Such as?
Unilateral ovarian enlargement and edema. The twisted ovary looks swollen, bigger than the other side, maybe with less defined borders. You might see the ovarian follicles pushed out to the periphery of the follicular ring sign. The ovary or mass might be pulled towards the midline.
What about blood flow on the ultrasound? Isn't that diagnostic?
It's crucial, but can be tricky. Seeing absent arterial or venous blood flow within the ovary on Doppler is highly suggestive of torsion, especially if it's been twisted for a while. However, in early or intermittent torsion, some flow might still be present, or you might just see abnormal flow patterns like coiling vessels. Sometimes you can directly visualize the twisted pedicle itself, the whirlpool sign on grayscale or color Doppler. The ovary might also look solid or have mixed echogenicity due to internal hemorrhage or early necrosis. Free fluid in the pelvis is also common. So while absent flow is a strong sign, presence of flow doesn't rule it out if other features are suspicious.
So if torsion is suspected, what's the management?
It's surgical. The source says laparoscopy is the usual approach. Figure 87.7 shows this. The main goal is to torsion, gently untwisting the ovarian tube. If there's an underlying cyst, the source suggests performing an ovarian cystectomy either at the same time, if feasible, or planning it for a later date once the ovary has recovered and the swelling has gone down. This helps prevent recurrence and reduces the chance the ovary might need removing later. The aim is always salvaging the ovary if it looks viable after detorsion.
Okay, let's shift from acute pain now to chronic abdominal pain. Source focuses on two major players here, endometriosis and adenomyosis. Let's start with endometriosis.
Endometriosis, it's a really common, often debilitating inflammatory condition. It affects mainly women of reproductive age. The definition is the presence of tissue that resembles the endometrium, the uterine lining, but growing outside the uterus.
Where does this tissue typically show up?
Most commonly, as the source describes, it's found on the pelvic organs, ovaries, fallopian tubes, bowel, bladder, and on the peritoneum, that lining of the pelvic and abdominal cavity. But it's not always confined there. The source notes it can occasionally occur in distant sites like the diaphragm or even the lungs. This can lead to really unusual symptoms like cyclical chest pain or even coughing up blood, hemoptysis, or having a collapsed lung, pneumothorax, that occurs specifically during menstruation.
Wow, that really highlights its potential reach. Is the cause known?
The exact mechanism isn't fully nailed down, according to the source, but the most widely believed theory is retrograde menstruation. The idea is that during a period, some menstrual blood containing endometrial cells flows backwards out through the fallopian tubes into the pelvis, where these cells can implant and grow.
How common is it believed to be?
Estimates vary, but the source suggests around 5 to 10% of all women of reproductive age are affected, and the prevalence is likely higher in certain groups, like women experiencing infertility.
What about symptoms? The source says they're really variable.
That's a key point. Many women with endometriosis, even quite extensive disease found at surgery, have no symptoms at all. For those who do, the symptoms can overlap significantly with other conditions like irritable bowel syndrome, IBS, or interstitial cystitis, making diagnosis tricky based on symptoms alone. However, pain is the most common symptom, often considered the hallmark.
What kind of pain are we talking about?
It can be cyclical, related to the menstrual cycle, maybe worse during periods, or ovulation pain. Or it can be chronic, non-cyclical pelvic pain. Specific types of pain listed include dysmenorrhea, painful periods, often severe and progressive, deep dyspareunia, pain during or after deep intercourse, dyschezia, painful bowel movements, especially during periods, and dysuria, painful urination, often cyclical. Other associated symptoms can include chronic fatigue, infertility, hematuria, blood in urine, or cyclical rectal bleeding, matutesia.
And the disease itself can look very different from person to person.
Hugely different. It can range from just a few small superficial spots, lesions on otherwise normal-looking organs, right up to severe, deeply infiltrating endometriosis and large ovarian cysts filled with old blood called endometriomas. The source notes that endometriomas are often a sign of deeper disease elsewhere. There can also be extensive scarring, fibrosis, and adhesions where organs get stuck together, which can really distort the normal pelvic anatomy.
Does the amount of disease correlate with symptom severity?
That's another important point the source makes. Often it doesn't. There are classification systems based on surgical findings, but they frequently show little correlation with the type or severity of symptoms a woman experiences. Someone with minimal disease might have terrible pain, while someone with extensive adhesions might have few symptoms.
What do these endometriosis lesions actually look like if you see them during surgery?
The classic or typical appearance described is often powder burn or gunshot lesions. These are small, puckered spots that look black, dark brown, or bluish. They represent areas of old bleeding within the implanted tissue, usually surrounded by some scarring or fibrosis. But they don't always look like that. The source mentions atypical or subtle lesions too. These can be red implants, described as petechial, vesicular, polypoid, hemorrhagic, red flame-like, or even clear blisters, serous vesicles. Other appearances include white plaques or scarring, or yellowish-brown discoloration of the peritoneum.
And those ovarian cysts, endometriomas.
They have a characteristic appearance. They're cysts within the ovary filled with thick, dark, altered blood, often described as looking like melted chocolate or tar. The source says they're found in 44% of women with endometriosis. A key feature is that they are usually densely adherent, stuck down to the surrounding structures like the pelvic sidewall, the back of the uterus, and the fallopian tube. The inflammation and fibrosis around them can even involve the bowel wall.
And deep endometriosis has a specific definition.
Yes. It's defined as endometriosis tissue that has infiltrated 5 millimeters or more beneath the surface of the peritoneum. It commonly grows into structures like the uterosacral ligaments, which support the uterus, the vagina, the bowel wall, the bladder wall, or even surrounding the ureters. Vaginal lesions can sometimes be seen during a speculum exam, often appearing as bluish cysts in the posterior fornix. Deep bowel lesions can be particularly challenging as they can mimic bowel cancer in presentation.
So how is endometriosis definitively diagnosed?
According to the source, the gold standard remains laparoscopy, looking inside with the camera, combined with histological confirmation. That means taking biopsies of suspicious areas and having a pathologist confirm the presence of endometrial glands and stroma under the microscope.
What about non-invasive methods?
Non-invasive tools like transvaginal or transrectal ultrasound are useful, but the source states they can generally only reliably detect the more severe forms, like endometriomas or significant deep pelvic endometriosis nodules. MRI can also be helpful, particularly for detecting deep disease, as it can sometimes show the hemorrhagic deposits from old blood.
And if bowel involvement is suspected?
Sigmoidoscopy might be used to get more information about how far up the bowel a lesion extends, especially in deep rectosigmoid endometriosis. The source highlights the clinical relevance here for surgical planning. Knowing the distance of the lower edge of the lesion from the anal verge is crucial. Lower rectal lesions, say 5 to 8 centimeters from the verge, carry higher risks for complications like anastomotic leaks if resection is needed, and also a higher risk of temporary nerve injury affecting bladder function.
What might a clinician find on physical examination?
Examination findings can be suggestive but aren't always present. Things like pelvic tenderness, a fixed retroverted uterus, stuck backwards due to adhesions, tender or nodular uterosacral ligaments, or enlarged ovaries, suggesting endometriomas. The diagnosis becomes more certain if definite, deeply infiltrating nodules are felt, or if lesions are actually visible in the vagina or on the cervix. A digital rectal exam is important to feel for bowel involvement or extension towards the pelvic sidewalls. But crucially, the source emphasizes that the examination can be entirely normal, even with significant endometriosis.
Treatment options seem somewhat limited, reflecting the uncertainty about the exact cause.
Yes, the source notes the limitations. Management strategies include conservative approaches like simple pain relief, analgesia. Medical management focuses on hormonal treatments to suppress ovarian function and reduce estrogen levels, which helps shrink or stabilize the lesions and reduce pain. Examples listed include progestogens, the levonorgestrel-releasing intrauterine system, LNG-IUS, and GnRH agonists, often needing add-back HRT to manage side effects like hot flushes and bone loss. Surgical management involves either destroying the lesions, ablation, or cutting them out, excision.
It sounds like it could be a really challenging condition to manage long-term.
It definitely can be. The source mentions that women often require multiple surgeries over their lifetime and need prolonged medical treatments, which can be costly and have burdensome side effects. Surgical planning is complex, especially with deep disease. The proximity to the ureter is a major concern. Scarring around the ureter can cause strictures, potentially leading to kidney damage, hydronephrosis, if urine flow is blocked.
And the surgical risks are higher in these complex cases.
Yes. Standard laparoscopic risks like damage to bowel, bladder, or ureters exist in any pelvic surgery, quoted around 2 per 1,000. But these risks are increased with deep endometriosis because the anatomy is often distorted by adhesions and fibrosis, pulling structures like the ureter out of their normal path. Risks are also higher in repeat surgeries. Repeatedly dissecting the ureter, ureterolysis, increases the risk of damaging its blood supply, ischemia, and repeatedly shaving disease off the bowel can weaken the wall, increasing fistula risk. Any bowel surgery, planned or accidental, carries the risk of fecal peritonitis if there's a leak.
Are there ways to check the bowel integrity during surgery?
The source mentions a few techniques. Gently stretching the bowel over a probe in the rectum can help identify thin spots. Filling the pelvis with saline and then insufflating air into the rectum, the bubble test, can show air bubbles escaping if there's a hole. Injecting methylene blue dye into the rectum is another way to look for leaks visually.
What about ureteral stents?
They might be placed during surgery, especially if the ureter was heavily involved in disease or if operating near the bladder trigone. They help keep the ureter open while it heals, usually removed after about 6 weeks. If the bladder itself is opened and repaired, a urinary catheter is typically left in place for 8-10 days, and a cystogram, X-ray with dye, is often done before removal to check the repair has healed.
A rare complication mentioned.
Infection developing within an endometrioma, potentially leading to a tubo-ovarian abscess.
Fertility goals heavily influence treatment decisions, don't they?
Hugely. For a woman who has completed her family and suffers significantly, the source suggests that hysterectomy plus removal of both ovaries and tubes, bilateral salpingo-oophorectomy, combined with excising all visible endometriosis, offers the best chance of cure and preventing recurrence. But if a woman wants to preserve her fertility, the surgery needs to be much more conservative, aiming to keep the uterus and preserve ovarian function. The goal becomes removing as much disease as possible while restoring normal anatomy to improve chances of conception, either naturally or with assistance.
Is there a specific recommendation for handling endometriomas when preserving fertility?
Yes. The source suggests that to best preserve ovarian function, the preferred approach for endometriomas is often cyst drainage combined with directed ablation, using energy to destroy the cyst lining, rather than stripping out the entire cyst wall, cystectomy. The rationale mentioned is that most oocytes are near the surface. However, it immediately cautions that this drainage ablation approach carries a higher risk of the cyst recurring compared to cystectomy. For women with cysts in both ovaries, the source suggests considering preoperative egg freezing, oocyte cryopreservation, due to the potential impact of surgery on ovarian reserve. It also notes that choosing bowel shaving over full resection might risk leaving disease behind.
Are there standardized ways to classify the severity?
Several classification systems exist based on surgical findings, but the source notes there isn't one universally accepted international system yet. It does mention the endometriosis fertility index as having shown good predictive value for pregnancy chances after surgery.
And endometriosis carries some associated long-term health risks.
Unfortunately, yes. The source states that women with endometriosis have an increased risk of developing certain types of ovarian cancer, specifically endometrioid and clear cell types. There's also an association with an increased risk of non-Hodgkin's lymphoma. These add to the overall burden of the disease.
Okay, let's move to the second condition discussed under chronic pain. Adenomyosis.
Adenomyosis, another benign uterine disorder, but distinct from endometriosis. Here, the ectopic endometrial tissue glands and stroma, like the uterine lining, is found within the myometrium, the actual muscle wall of the uterus. This is often accompanied by hypertrophy or hyperplasia, meaning thickening or enlargement of the surrounding muscle tissue.
So endometriosis is outside the uterus, adenomyosis is inside the muscle wall.
Exactly. It's like the lining has grown into the muscle. This misplaced tissue can be spread diffusely throughout the uterine wall, or it can form a focal mass, sometimes called an adenomyoma, which can mimic a fibroid.
The source describes it as complex to diagnose and manage.
It is, largely because its presentation is so variable. Symptoms can be nonspecific, making diagnosis difficult, which then makes choosing the right management challenging. Its true prevalence is hard to pin down. Studies have reported rates anywhere from 1% up to 70%, likely reflecting different diagnostic criteria used over time.
Table 87.4 covers its characteristics. How does it typically present?
Symptoms often overlap with other conditions, like fibroids or endometriosis. Common ones include heavy or prolonged menstrual bleeding, abnormal uterine bleeding, painful periods, dysmenorrhea, chronic pelvic pain, subfertility, and painful intercourse, dyspareunia. But some women are asymptomatic. It tends to present most often in women in their 40s and 50s. On examination, the uterus might feel enlarged and tender. Hysteroscopy might show subtle signs like an irregular endometrial surface, small defects, cystic hemorrhagic spots, or altered vascular patterns.
What are the risk factors for developing adenomyosis?
The source lists several potential factors. Things that increase estrogen exposure seem relevant. Early menarche, periods starting age 10 or younger. Short cycles, 24 days. Higher BMI, potentially oral contraceptive use, increasing age, and tamoxifen use. Past uterine events are also implicated. Spontaneous miscarriage, multiple pregnancies, increasing parity, number of births, and any uterine instrumentation or incision C-sections, terminations, D&Cs, conditions like endometrial hyperplasia, fibroids that disrupt the endometrial-myometrial border, coexisting endometriosis, and smoking are also listed as potential risk factors.
Diagnosis sounds challenging. What tools are used?
Ultrasound is key. The source mentions the MUSA, Morphological Uterus Sonographic Assessment Group recommendations, which suggests systematically looking for specific features. Typical ultrasound signs include an enlarged, often globular-shaped uterus, frequently with asymmetrical thickening of the walls. You might see small cystic spaces within the myometrium, bright spots, echogenic subendometrial lesions or hyperechogenic islands, fan-shaped shadowing behind these areas, an ill-defined or irregular junctional zone, the boundary between endometrium and myometrium, and sometimes increased vascularity on color Doppler. Figures 87.14, 87.17 illustrate these. Usually needing 3 or more of these features strengthens the diagnosis. Ultrasound can also help distinguish a focal adenomyoma from a fibroid.
Is MRI useful here too?
Yes, MRI can be very helpful, particularly in differentiating adenomyomas from fibroids, which can influence treatment choices. Historically, the definitive diagnosis was only made after hysterectomy by examining the uterine tissue under a microscope, which obviously isn't helpful for women wanting to keep their uterus.
So management options have evolved beyond just hysterectomy.
Definitely. Options include medical management, radiological minimally invasive interventions, and surgical options, both uterus-preserving and non-preserving. Medical management starts with pain relief like NSAIDs. Hormonal treatments aim to suppress the ectopic endometrial tissue and reduce bleeding. Examples include the LNG-IUS, off-label but often used, combined contraceptive pills, off-label, progestogens like Dianogest, GnRH agonists-antagonists, danazol, aromatase inhibitors like letrozole, and selective progesterone receptor modulators.
What about those non-surgical interventions?
High-intensity focused ultrasound, HIFU, or MR-guided focused ultrasound, MRGFUS, use focused energy to destroy the adenomyotic tissue. The source lists potential side effects: abdominal pain, skin burns, leg pain from nerve heating, bowel injury, and temporary kidney issues. Uterine artery embolization, UAE, is another option, blocking blood flow to the affected areas. It can cause post-embolization syndrome, pelvic pain, nausea, fever due to tissue necrosis. Complications can include radiation exposure, bleeding, infection, thrombosis, need for surgery, and potential impact on ovarian function.
And surgery. Can the uterus be preserved?
Yes, uterus-preserving surgery involves removing the adenomyotic tissue, called adenomyomectomy. The source mentions different techniques depending on whether the disease is focal or diffuse. Non-excisional methods like thermal coagulation, partial reduction surgeries like wedge resections from diffuse disease, or complete excision techniques for focal adenomyomas, sometimes involving complex reconstructions like double or triple flaps. The goal is to remove the disease while maintaining uterine integrity.
And non-uterus preserving surgery.
Hysterectomy remains the definitive treatment. The source recommends total hysterectomy, including the cervix, over subtotal, as adenomyosis-like tissue can sometimes recur in the cervical stump. Endometrial ablation resection is another option, but generally less effective for adenomyosis than for heavy bleeding from the lining alone because the disease is deep in the muscle.
What are the risks associated with adenomyomectomy, the uterus-preserving surgery?
The source highlights some significant potential complications, particularly concerning future pregnancy. There's a reported risk of uterine rupture during pregnancy or labor, possibly higher than after myomectomy, fibroid removal, with rates up to 6% cited in some studies versus perhaps 1% generally after adenomyomectomy, and lower, around 0.26% after myomectomy. This includes silent rupture. There's also a higher risk of placental problems like placenta accreta spectrum, Ashman syndrome, Intrauterine scarring is a risk, as is disease recurrence.
The source mentions a few historical figures here.
Thomas Hodgkin, Joseph Gustav Aschermann, associated with intrauterine adhesions, Aschermann syndrome, though Heinrich Frisch apparently described it first.
Okay, let's move into our final major clinical section, abnormal uterine bleeding, or AUB, in women who aren't pregnant.
AUB is incredibly common. It's basically any uterine bleeding that falls outside the normal pattern of menstruation. This could mean periods that are excessively heavy, last too long, or occur too frequently. It also includes bleeding between periods, intermenstrual bleeding, IMB, bleeding after intercourse, postcoital bleeding, PCB, or perhaps most significantly, any bleeding after menopause, postmenopausal bleeding, PMB.
And menopause is defined as 12 months without periods.
That's right, assuming no hormonal contraception is suppressing periods.
Yes.
The source also adds that bleeding can occur after procedures like IUCD insertion or endometrial biopsy.
The source classifies the main causes neatly.
Table 87.5 uses the PALM-COAN system framework, dividing causes into structural, POM, and non-structural COAN. Structural causes are physical abnormalities, polyps, endometrial or cervical, adenomyosis, which we just discussed,
right,
leiomyoma, fibroids, especially submucosal or intramural distorting the cavity, and malignancy or hyperplasia, endometrial hyperplasia or cancer, cervical cancer, etc.
And the non-structural causes, COAN.
These are coagulopathy, bleeding disorders like von Willebrand's disease, ovulatory dysfunction, irregular cycles, common in PCOS, endometrial causes like endometritis or local issues with hemostasis, iatrogenic, caused by medical treatment like hormonal contraceptives, anticoagulants, IUCDs, and not otherwise classified, rare things like arteriovenous malformations, systemic diseases, and endometriosis can also contribute.
Table 87.6 helps link the timing of bleeding to likely causes.
Yeah, it's a helpful way to think. Bleeding mainly manifesting as heavy periods might point towards endometrial polyps, malignancy, or fibroids. Bleeding between periods could suggest vaginal issues, trauma, malignancy, cervical problems, polyp, ectropion malignancy, or endometrial polyps malignancy. Postcoital bleeding specifically raises concern about the cervix, ectropion, polyp malignancy, or vagina malignancy. The source notes some cancers listed are mainly postmenopausal issues.
So the main goal of managing AUB is finding the cause.
Exactly. The source states the mainstay is to identify and treat the underlying pathology, so investigation is key.
What investigations are typically done?
First, always rule out pregnancy with a pregnancy test. Then, pelvic ultrasound is crucial, often transvaginal, 2D, 3D, maybe with saline infusion sonography to get a better look inside the cavity. A core investigation is endometrial biopsy sampling the uterine lining. This can be done blindly with a Pipelle device in clinic, or preferably under direct vision during hysteroscopy, looking inside with a camera. The source highlights that combining hysteroscopy with biopsy gives the best diagnostic accuracy for detecting endometrial pathology.
Are there specific triggers for doing an endometrial biopsy? The source lists indications?
Yes. Summary box 87.2 details when it's strongly recommended. If endometrial pathology is suspected based on symptoms or imaging, definitely in women over 45 where initial medical treatment for AUB hasn't worked. For persistent intermenstrual bleeding, if ultrasound shows endometrial thickness over 4 millimeters in a postmenopausal woman, or if it's persistently thick, 7 millimeter, or abnormal looking in a premenopausal woman, especially with PCOS. For irregular bleeding on HRT after the first few months, and also in younger women if they have major risk factors for endometrial cancer or hyperplasia like PCOS, obesity, tamoxifen use, bleeding on unopposed estrogen, or a strong family history like Lynch syndrome.
Colonoscopy is mentioned again here.
Yes, occasionally if the bleeding pattern is unusual or there are bowel symptoms, a colonoscopy might be needed to rule out a colorectal source of bleeding.
The source flags special patient groups with higher risks for AUB related to potentially serious causes.
Women taking tamoxifen for breast cancer are a key group. Tamoxifen, while anti-estrogenic in the breast, acts like an estrogen on the uterus. It can cause abnormalities like polyps, hyperplasia, and even endometrial cancer or rare uterine sarcomas in 10–40% of users.
That's a significant risk.
It is. The source says tamoxifen doubles the endometrial cancer risk after 1–2 years, quadruples it after 5 years. The risk depends on duration, not dose, and importantly, doesn't go down after stopping. There's no consensus on routine screening, so the common practice is to investigate only those who develop bleeding while on it. This is contrasted with aromatase inhibitors, another breast cancer drug class, which don't stimulate the endometrium.
And women with Lynch syndrome.
They have a very high lifetime risk of endometrial cancer, up to 60%, often diagnosed earlier, in their 40s or 50s. Survival seems similar to sporadic cases. International guidelines, noted by the source, often suggest annual screening from age 35 with transvaginal ultrasound and endometrial biopsy. Genetic counseling is vital for these families.
Cervical cancer is another cause of AUB.
Yes, particularly postcoital or irregular bleeding. Thankfully, screening programs have drastically cut its incidence by detecting precancerous changes, CIN.
How does UK screening work now?
The source explains the current approach. The sample is first tested for high-risk HPV types like 16, 18, 31, 33. If positive, then the sample is checked for abnormal cell changes, cytology. The aim is to catch and treat CIN before it becomes cancer. The schedule is every 3 years aged 25-49, every 5 years aged 50-64, with catch-up if needed over 65.
And if abnormal cells are found.
Referral for colposcopy, that magnified look at the cervix, often with biopsies. If CIN is confirmed, treatment involves local ablation, destroying the abnormal cells, for example, cold coagulation, or excision, cutting them out, for example, LETZ procedure.
HPV vaccination must be helping too.
That's the goal. Vaccinating adolescents against high-risk HPV types aims to prevent infection and therefore reduce cervical cancer rates long-term. The source notes the UK program targets 12-13-year-olds, ideally before sexual activity starts, and mentions protection against other HPV-related cancers too.
What if the heavy bleeding doesn't have an obvious structural cause? Dysfunctional uterine bleeding, DUB.
Right. That term refers to excessively heavy, irregular, or frequent bleeding without identified pathology. The source mentions UK NICE guidance suggests a stepwise treatment approach for heavy menstrual bleeding, HMB, shown in Table 87.7.
Let's walk through the investigation and management of HMB from that table.
Investigations focus on ruling out underlying causes. TVUS is first line, MRI if needed. Hysteroscopy with biopsy provides direct visualization and tissue sampling. Once structural causes are addressed or ruled out, management focuses on controlling the bleeding itself.
Starting with medical options.
Medical management includes non-hormonal options like tranexamic acid, reduces fibrinolysis, helps clotting, or NSAIDs, off-label reduce prostaglandins. Hormonal treatments aim to suppress the endometrium. The levonorgestrel IUS, LNG IUS, is highly effective, causing significant reduction in blood loss, even amenorrhea in many. Combined oral contraceptive pills, off-label, progestogen-only pills like desogestrel, off-label, or cyclical progestogens are other options. GnRH agonists can shrink fibroids temporarily but cause menopausal side effects and aren't a long-term fix on their own. The source also mentions ulipristal acetate, Esmaya, and SPRM, licensed for some premenopausal women, but carries a warning about liver injury risk requiring monitoring.
And the radiological minimally invasive options.
HIFU-MRGFUS for fibroids causing HMB, and uterine artery embolization, UAE, to block blood supply to fibroids. UAE is often considered better for single large fibroids than multiple ones. Remember the post-embolization syndrome and other potential complications.
And surgical management, either preserving the uterus or not.
Uterus-preserving surgery addresses structural causes. Hysteroscopic polypectomy or transcervical resection of fibroids, TCRF. For polyp submucosal fibroids within the cavity, risks include perforation, fluid overload, injury. Myomectomy, open or laparoscopic, removes fibroids from the uterine wall, risks bleeding, injury, very low risk of needing hysterectomy. Morcellation comes up again here.
Non-uterus preserving surgery.
Endometrial ablation or resection aims to destroy the uterine lining using energy. It's not for women wanting future fertility. Success rates are good for reducing bleeding, with many becoming amenorrheic. Table 87.8 lists criteria like uterine size 10 centimeters, no major cavity distortion, no prior ablation, family complete. Hysterectomy is the definitive option, total preferred over subtotal. Risks include injury to surrounding organs, fistula.
Choosing the right path seems very personalized.
Absolutely. The source stresses individualization based on cause, symptoms, fertility, desires. If hysterectomy is chosen, the route, vaginal, abdominal, laparoscopic, depends on many factors. No clear difference in long-term prolapse or sexual function between total and subtotal hysterectomy is reported.
And the recommendation about fallopian tubes.
Yes, modern practice recommends removing the fallopian tubes, salpingectomy, whenever hysterectomy is performed, even if ovaries are kept. Tubes serve no function then, and removing them reduces the future risk of ovarian cancer, much of which is now thought to start in the tubes. Ovary removal depends on age, pathology, cancer risk factors.
Historical figures mentioned.
Eric Odolph von Willebrand, bleeding disorder, and Henry T. Lynch, cancer syndrome.
Let's focus specifically now on uterine fibroids, leiomyoma, as they're such a common cause of AUB and other symptoms.
Fibroids, extremely common. They're benign, well-circumscribed tumors arising from the smooth muscle of the uterine wall, the myometrium.
And the risk of them being cancerous, leiomyosarcoma.
Very low. The source states malignant transformation risk is less than 1%.
How common are they, and where do they grow?
Very common, especially in women of African Caribbean descent. They vary hugely in size and number. Figure 87.21 shows the typical locations. Subserosal fibroids grow on the outer surface, maybe causing pressure. If pedunculated on a stalk, they can mimic ovarian tumors. Intramural fibroids are within the muscle wall, can cause pressure, heavy periods, or infertility if large or distorting the cavity. Submucosal fibroids bulge into the uterine cavity beneath the lining, strongly linked to heavy bleeding, infertility, miscarriage. Pedunculated ones can even prolapse through the cervix sometimes. Rare sites include the broad ligament or cervix itself.
What symptoms do they cause?
Heavy and/or irregular periods are classic, potentially leading to anemia. Pressure symptoms are also common depending on size and location. Pelvic discomfort, urinary frequency urgency retention, constipation, backache. Very large ones can cause venous compression, leading to leg swelling or varicosities. And it's but many women are completely asymptomatic.
Can they present acutely?
Rarely. Acute pain can happen if a pedunculated fibroid twists on its stalk, torsion, or due to red degeneration, painful infarction, or necrosis within the fibroid, especially common during pregnancy when they can outgrow their blood supply.
How are they usually diagnosed?
Often suspected on pelvic exam, enlarged irregular uterus. The main differential is an ovarian mass, but usually the uterus feels enlarged with the fibroids attached. Pelvic ultrasound is the first-line investigation, very sensitive and specific. MRI is excellent for detailed mapping if needed, or if ultrasound is unclear.
And treatment approaches?
Highly variable. Depends on symptoms, age, fertility plans, fibroid size, location. Options range from watchful waiting, conservative if asymptomatic, to medical treatments for bleeding, hormonal therapies to shrink fibroids temporarily, like GnRH agonist before surgery, or surgery either uterus-preserving myomectomy or non-preserving hysterectomy. Emergency surgery is rare, only for severe bleeding or pain.
This source comes back to morcellation here, specifically in fibroid surgery.
Yes. Morcellation, as we discussed, is breaking up tissue, like fibroids during laparoscopic myomectomy or the uterus in subtotal hysterectomy, into smaller pieces for removal through small incisions. Uses a morcellator device.
What are the specific risks highlighted with morcellation?
Two main concerns. Parasitic spread. Tiny fragments of benign fibroid tissue can implant elsewhere and grow. Reported rates vary, 1.120 to 1.1200. The bigger concern is potentially upstaging an unsuspected malignancy. If a mass thought to be a fibroid is actually a rare uterine sarcoma, morcellating it can spread cancer cells widely in the abdomen, worsening the prognosis significantly. This risk also exists in open surgery if a sarcoma capsule is breached, but morcellation might disseminate more widely. It can also make histological diagnosis harder. Retrieval bags aim to contain tissue, but robust evidence is pending. Careful case selection is paramount.
What increases suspicion that a fibroid might actually be a sarcoma?
Factors raising suspicion include increasing age, peripostmenopausal, known genetic risks like BRCA or Lynch syndrome, and importantly, a rapidly growing uterine mass, especially if it doesn't respond as expected to estrogen deprivation therapies.
Okay, let's move into the final major section, urogynecology, covering urinary incontinence and uterovaginal prolapse.
Gynaecology deals with pelvic floor disorders. Urinary incontinence, UI, is a huge issue in voluntary leakage of urine. It's incredibly common, maybe 30% of women experience it, more so with age, and it really impacts quality of life.
How is UI classified?
The main types are stress urinary incontinence, SUI leakage, with effort like coughing, sneezing, laughing, exercise. Overactive bladder, OAB, characterized by urgency, sudden need to go, often with frequency and nocturia, waking at night, sometimes with urge incontinence, leaking with the urge, and mixed urinary incontinence having both SUI and OAB symptoms.
What causes UI?
Lots of things. Functional or anatomical, multiparity, multiple births, childbirth trauma, vaginal delivery, increasing age, menopause, estrogen loss, fistulas, urethral issues like diverticula or congenital anomalies, ectopic ureters, immobility, chronic constipation, UTIs, chronic medical conditions, heart failure, diabetes, MS, certain medications like diuretics, pelvic masses pressing on the bladder, and obesity.
What are the common symptoms people complain of?
Often grouped into storage or emptying symptoms. Storage, frequency, going 8 times a day, urgency, nocturia, once a night. Emptying, hesitancy, trouble starting, slow stream, feeling of incomplete emptying, straining. Plus the leakage with exertion typical of SUI, hematuria, blood and urine in women over 40, always needs investigation to exclude malignancy.
How is it investigated?
Starts with questionnaires, bladder diaries, tracking intake output, pelvic exam, urine tests for infection. Urodynamic specialized bladder function tests are used if conservative measures fail, the type is unclear, or symptoms recur after surgery. Ultrasound of the urinary tract if recurrent UTIs or hematuria. Cystoscopy, looking inside bladder if pathology suspected.
And management.
Ranges from conservative methods to medical therapy to surgery. Depends on the type and cause. Treatments can be combined, individualized. MDT discussion is recommended for complex or recurrent cases.
Let's look at the specifics, starting with OAB management, table 87.9.
Conservative. Lifestyle changes, limit fluids, avoid irritants like caffeine, weight loss, behavioral therapy, bladder training for 6 weeks, review meds. Pelvic floor muscle training and intermittent self-catheterization are listed for both OAB-SUI.
Medical therapy for OAB.
Anticholinergics are common. Oxybutynin, tolterodine, relax the bladder, reduce urgency. Side effects, dry mouth, constipation. Caution with oxybutynin in frail elderly due to cognitive risks. Mirabegron, a bacteria agonist, is another option, works differently. Desmopressin specifically targets nocturia.
Surgical procedural options for OAB.
Intravesical botulinum toxin A injections, Botox into bladder muscle. Neuromodulation, tibial nerve or sacral nerve stimulation for severe refractory cases. Augmentation cystoplasty, enlarging bladder with bowel major surgery with significant risks like metabolic issues, mucus, retention, long-term cancer risk. Urinary diversion is a last resort.
Now for SUI management, table 87.10.
Conservative, intensive pelvic floor muscle training, 3 months, 8 contractions, 3 a day. Managing chronic cough, medical. Duloxetine and SNRI can be tried if conservative fails and surgery isn't wanted possible.
Surgical options for SUI focus on supporting the urethra.
Exactly. Colpo suspension, open or laparoscopic bladder neck suspension, autologous rectus fascial sling using patient's own tissue, retropubic midurethral mesh slings, synthetic tape, periurethral bulking agents, injections, artificial urinary sphincter for severe cases. The source explicitly lists procedures not offered anymore. Anterior repair for SUI, needle suspensions, perivaginal repair, porcine slings, Marshall-Marchetti krantz.
Table 87.11 covers UI from specific causes.
If it's a pelvic mass, remove the mass. Recurrent UTIs, antibiotics, treatment prophylaxis, vaginal estrogen in postmenopausal women, fistula or ectopic ureter requires surgical correction.
Shifting now to the other major urogen issue, uterovaginal prolapse.
Pelvic organ prolapse. Very common. It's when pelvic organs, bladder, uterus, rectum, bulge or descend into or out of the vagina, affects up to 40% of women lifetime, impacting urinary, bowel, and sexual function significantly.
What increases the risk?
Older age, having had children, especially multiple difficult or vaginal deliveries, obesity, chronic straining, constipation, heavy lifting, estrogen deficiency, menopause, family history genetics, connective tissue disorders, either as Danlos, Marfan.
And the symptoms depend on what's prolapsing.
Generally, yes, figure 87.23. Minor prolapse might be asymptomatic, more significant, a feeling of something coming down. Cystazzle, bladder prolapse, lump, urinary symptoms, OAB, UTIs, uterine descent, lump dragging sensation, procedentia, uterus fully out, discharge, ulceration, bleeding, recticell, rectum prolapse, difficulty emptying bowels, needing to push it back digitally.
Is there a grading system?
Yes, the pelvic organ prolapse quantification system, POPQ. It's a standardized way to measure and grade the descent relative to the hymen, from grade 0, none, to grade 4, max.
Well, what about non-surgical management?
Lifestyle changes. Avoid constipation, weight loss. Pelvic floor physiotherapy, effective for grade 12. Topical estrogen if deficient. Vaginal pessaries devices inserted to support the organs. Many types, ring pessary commonest. Need regular changing, 3 to 6 months. Complications. Ulceration, infection, discharge, bleeding.
And surgical management.
Aims to correct the anatomy and support the organs. Can be vaginal or abdominal open laparoscopic approaches. Table 87.12.
Let's look at surgeries for specific types from the table.
Urethrocelicystocele, anterior prolapse. Anterior vaginal wall repair, anterior colporrhaphy, usually without mesh now. Risks. bleeding, infection, fistula, voiding issues, unmasking SUI, failure, recurrence.
Uterine prolapse.
If family complete, vaginal hysterectomy plus sat vault support, like sacrospinous fixation. Uterus preserving options, Manchester repair, cervical amputation plus ligament application, laparoscopic uterosacral ligament application, McCall suture, hysteropaxy, suspending uterus vaginally or abdominally laparoscopically, sometimes with mesh for sacrohysteropaxy. Colpoclasis closes the vagina for those not sexually active. Risks, standard surgical risks, plus specific ones like infertility miscarriage with Manchester repair.
Enteroseal.
Repairs like a hernia repair, vaginally reduce the bowel, close the defect. Risks, bleeding, infection, bowel injury, dyspareunia, failure, recurrence.
Vaginal vault prolapse after hysterectomy.
Sacrospinous fixation, vaginally attaching vault to ligament, usually right side. Sacrocolpopexy, abdominally laparoscopically using mesh to suspend vault to sacrum. Colpoclasis, risks, bleeding, infection, injury, SUI, unmasking, buttock pain, sacrospinous, sexual dysfunction.
Rectocil, posterior prolapse.
Posterior colpoperineorrhaphy, posterior repair, usually without mesh. Open posterior wall, push rectum back, repair fascia, excess mucosa. Risks, bleeding, infection, rectal injury, fistula, dyspareunia, failure, recurrence.
Recurrence seems like a big problem with prolapse surgery.
It is. The source quotes around 30% recurrence reporting symptoms lifetime, higher with repeat surgeries. It's a real challenge.
Which brings us back to surgical mesh. Highly controversial.
Extremely. Its use for SUI and prolapse is now under heavy scrutiny and restriction in the UK due to significant safety concerns about long-term complications.
All kind of complications.
The source lists many. Chronic pain, pelvic, leg, groin, back, sensory changes, vaginal issues, erosion, discharge, bleeding, painful sex for patient partner, urinary problems, infections, incontinence, retention, difficulty voiding, bowel problems, difficulty defecating, pain, incontinence, rectal bleeding.
How are mesh problems managed?
Requires an MDT approach in specialist regional centers experienced in diagnosing and managing mesh complications.
So has mesh use changed?
Significantly. For SUI, transvaginal transobturator tapes are largely replaced by non-mesh options like Colpo suspension or fascial slings. For prolapse, especially apical prolapse, bolt uterus, mesh can still be used in procedures like sacrocolpopexy or sacrohysteropexy, but only after very detailed counseling and MDT agreement. Anterior-posterior repairs are generally done without mesh.
Historical figures noted.
The Manchester repair, McCall suture, Ehlers, Danlos, Marfan, connective tissue disorders.
Right, our final major topic, tumors, specifically ovarian lesions, benign versus malignant.
Starting with benign ovarian tumors and cysts, good news first. The source says about 90% of all ovarian tumors are benign. Bad news. The risk of malignancy increases significantly with age, maybe 1 in 1,000 premenopausally, rising to 3 in 1,000 around age 50.
How are ovarian tumors classified?
The source uses the WHO classification, Table 87.13. Main categories: surface epithelial tumors, 65% overall, 90% of cancers. Types like serous, mucinous, endometrioid, graded benign, borderline malignant. Germ cell tumors, 15%. Commonest benign is mature teratodermoid cyst, often in younger women, can contain hair teeth. Malignant types include dysgerminoma, yolk sac tumor, sex cord stromal tumors, 10% arise from ovarian stroma, metastatic tumors, 5% of malignancies spread from breast, colon, stomach, etc., and miscellaneous.
How do benign tumors present?
Often asymptomatic, found incidentally, like that tooth on x-ray suggesting a dermoid, or can cause pain, dull ache, or sudden if torsion rupture, swelling, pressure symptoms, nausea, vomiting, sudden severe pain plus vomiting plus raised markers points more towards torsion, as we discussed.
How are benign cysts managed? Summary box 87.3, table 87.14.
Depends on age and cyst appearance. Pregnancy test first. Rare germ cell tumors can make HCG. Main tool is TVUS, very good at distinguishing benign malignant features. The source mentions the IOTA classification.
What are the IOTA B rules, benign versus M rules, malignant, on ultrasound?
B rules suggest benign. Unilocular cyst, small solid component, 7 mm, acoustic shadowing, e.g. dermoid. Smooth multilocular tumor, 100 mm, no blood flow. M rules suggest malignant. Irregular solid tumor, ascites, fort 4 papillary structures, irregular multilocular tumor, 100 mm, significant blood flow.
What if ultrasound is unclear?
MRI or CT might help. MRI, often better for complex cysts, features strongly suggesting cancer, complex cystic solid, irregular large ascites, usually warrant removal.
Tumor markers
can help but aren't perfect. Markers mentioned: BHCG, LDH, EJ, FP, CA125, CA199, CEA. For women 40 with complex complex masses, LDH, FP, inhibin, BHCG, are specifically recommended to check for germ cell tumors.
CA-125 is the famous one.
Yes, but highly nonspecific, normal 35 UMA-L, raised in 50% stage I, 90% advanced epithelial OC, but also raised in many benign conditions, periods, endometriosis, PID, liver disease, cystitis, and other cancers.
So CA-125 alone isn't enough?
No. That's why the risk of malignancy index, RMI, is used. Summary box 87.5. Combines menopausal status, M1 pre, M3 post, ultrasound score, U1 point per malignant feature up to 3, and CA125 level. RMI equals UXMXCA125 helps triage referrals to cancer centers.
Is there ovarian cancer screening?
No national program in the UK currently, even for high-risk women. No test is reliable enough for early detection yet. The source mentions the large UK CTOCS trial, which showed combined CA125 plus TVUS screening had higher specificity than TVUS alone, but didn't reduce mortality enough for population screening.
What about genetic risks?
BRCA1 and BRCA2 mutations significantly increase risk. BRCA1, 39% lifetime risk up to 70, BRCA2, 11-17%. Lynch syndrome genes also increase risk, 9-12%. Genetic counseling is key.
Can high-risk women have preventative surgery?
Yes. Risk-reducing bilateral salpingo-oophorectomy, removing ovaries and tubes, may be offered. This can also reduce breast cancer risk in BRCA carriers.
If ovarian cancer is suspected, how is it staged surgically?
Surgical staging, Table 87.15 summarizes stages IOV, is usually done via laparotomy, midline incision. It's a very thorough procedure.
What does it involve?
Careful inspection of all peritoneal surfaces. Peritoneal washings from 4 areas for cytology. Infracolic omentectomy, removing fatty apron. Pelvic and para-aortic lymph node sampling, lymphadenectomy. Biopsy removal of any suspicious lesions adhesions. Random biopsies from normal-looking peritoneum, diaphragm, bladder reflection, cul-de-sac, sidewalls. Total abdominal hysterectomy and bilateral salpingo-oophorectomy, TAH plus BSO. Appendicectomy for mucinous types.
A very comprehensive operation. What's the overall treatment principle?
Maximal cytoreductive surgery, debulking, removing all visible disease if possible, followed by combination chemotherapy. Bowel resection isn't always needed.
Are there exceptions for fertility preservation?
Yes. For young women with early stage I disease or borderline tumors, unilateral oophorectomy, removing just the affected ovary tube, might be considered after careful discussion.
Other fertility preservation techniques?
Oocyte or embryo freezing after ovarian stimulation has been done for low-grade early cancers but carries theoretical risks. Hormone effects, seeding cells, must be done cautiously with oncologists. Ovarian tissue freezing at surgery is experimental. Reimplantation later carries cancer recurrence risk.
Wow. We have really covered a huge amount of ground, from the absolute basics of anatomy right through to complex pathologies, diagnosis, management, and the nuances of cancer treatment. That truly was a deep dive.
We really have. We've extracted the essence of that textbook chapter, the fundamental anatomy, the critical conditions like ectopic pregnancy, torsion, the chronic challenges of endometriosis, adenomyosis, fibroids, the complexities of abnormal bleeding, the whole field of urogynecology with incontinence and prolapse, and finally, differentiating and managing ovarian tumors.
And the aim, as we said, was to guide you, our listener, to a level of understanding that genuinely approaches mastery of this material as presented in our source. We've laid out that framework, the key facts, the diagnostic logic, the management spectrum, including those important warnings about things like mesh and morcellation.
Hopefully, exploring this detail highlights not just the specific conditions, but how interconnected everything in the pelvis is, and how problems in one area affect others.
Which really sets up our final provocative thought for you to consider. We've spent this time delving into specific anatomical structures, distinct diseases, and targeted medical or surgical fixes. But when you consider the systemic impact of conditions like endometriosis, or the genetic links predisposing to multiple cancers, how might a more integrated understanding of overall health, things like inflammation, lifestyle, maybe broader genetic insights, play an even bigger future role in preventing and managing these conditions, perhaps shifting the focus beyond purely localized interventions?
It's a fascinating question. There's always more to learn and think about in this field.
Indeed. Thank you for joining us on this comprehensive deep dive into gynecology. We hope you feel significantly more informed and empowered by this detailed exploration.
Stay curious.